Okay. Welcome, everyone. Thank you for joining today's session. And apologies for the slight delay in beginning. Before we start, we would like to go over some of the housekeeping rules. So we will be using the chat function for question and answer. To use the chat, the button is at the bottom of your screen. Please send all questions that you have through the chat and feel free to introduce yourself. If you have any technological issues, send us a message through the chat and we'll do our best to help you. And the session is being recorded and your attendance is consent to being recorded, so thank you. So welcome to session 5. Today's topic is critical care outside the ICU, a rapid response. And as usual, we are so grateful to have Dr. Francois Xavier, Liberata, Dr. Joseph, Dr. Venuste, and Dr. Apollinaire. Dr. Francois is having some internet issues, and so I'll actually hand it over to Liberata to get us started.
Thank you so much, Alana, and a warm welcome to all participants of today's session. Hope you are hearing me well.
Yes.
Is my voice
well.
fine? Apology, my video is not working. So today's session is about the critical care outside of an ICU and how rapid response systems can intervene to save the life of someone if the ICU is not available. Next slide, please. This is again the title of the session of today. It's a critical care outside of an ICU. I know with our healthcare systems that we know, we don't have ICUs across the country. We mainly have them in the referral hospitals and referral and teaching hospitals. So it's very essential for us to know how we can provide critical care services outside of an ICU while we are waiting to transfer a patient where the ICU will continue to do the care for a critically sick patient. Next slide, please. Those are our partners. So as we know, we always base on case studies. Here we have a 50-year-old male patient with a history of coronary artery disease, hypertension, and type 2 diabetes mellitus, who was admitted 3 days ago to your COVID-19 isolation room. This morning on medical rounds, you saw him with shortness of breathing and tachypnea, with respiratory rate of 27, temperature of 38, blood pressure of 107/60 millimeter of mercury. Then heart rate was 97. You're working in a rural hospital, and the nearest hospital with an ICU is at 65 kilometers or 3 hours away by ambulance. Today, due to inclement weather, roads are closed. You see, there is no other choice except to use your skills and save this patient. While you are hesitating to his deterioration, he became unconsciousness and the new vitals are respiratory rate of 40, blood pressure of 63/25, heart rate is 147, SpO2 is 66%, and the temperature of 39. What is your interpretation of his clinical status and what do you do next? So this case is what we are going to discuss and see how those rapid response teams are really essential to be established in our local health facilities, because they can be able to save this patient while there is people are thinking about other options to refer or to transfer these patients. But meanwhile, the patients can be stabilized and wait for the next steps to be done. Next slide. So by the end of this session, we hope to define the critical care continuum. We will be able to understand the SPO2 goals for oxygen therapy, depends on the clients that we have. We define and utilize different scores which are used for critically sick patients, include key SOFA, MEWS, and key CSI. We will outline the life-threatening signs and symptoms indicating time critical care is needed. We identify the key personnel that offer time critical care, who are key personnel who will be needed. We will see if we have a rapid response team policy in our institutions. If they are there, we will make like a review and see if they really complete all requirements, or if it's not yet established, we will see how one can be created. Then we see how there can be like simulations of scenario to identify gaps and areas which needs improvement in the rapid response teams if we have them in place. Next slide, please.
Sure. And I think Dr. Francois has joined.
Yes, Dr. Francois, you are welcome. I would pass the floor to Dr. Veniste for key definitions for critical care. Dr. Francois, do you have something to say before Dr. Veniste starts?
I would say at the end, not now.
I think he's still network. Dr. Oh, thank you. Veniste,
Yeah.
the floor is yours.
Thank you very much, Liberata, for the nice introduction. Hear me well. Is it okay?
Yes, yes.
Thank you. As in the introduction, I'm Dr. Veniste. I'm a physician at PRE-ICU Hospital. Today, I'm pleased to be with you sharing knowledge on critical care, CONTINUUM. As a definition for critical care continuum, it's a continuous sequence of interlinked events from the very early moments of illness through the ICU stay and into the recovery and rehabilitation settings. So as you can see in the diagram or the graph, you see in the order paradigm, the services or units were working independently, and for now the new model is for hello. Can you hear me?
Yeah, we can hear you.
Yeah, we can hear you. You are a bit quiet though.
Oh, sorry. I was saying in the order model for critical care departments or services from emergency services to emergency room, ICU, and discharge to medical or surgical wards and home rehabilitation settings. So those services were working independently without like a very close collaboration. But with the new model, the critical care continuum is offered through interlink between all those services that are involved in all levels of care for critically ill or sick patient. So as you understand, critical care continuum is not limited to the care that is offered inside an ICU involves all the events or the care which is offered in the pre-ICU settings when the patient is in the ICU, but also when the patient is discharged outside the ICU. Next slide, please. So both critical care and intensive care are included in the critical care continuum. The way they differ or the similarities, generally overall they are mostly the same. It's about caring patients who are critically or very sick. But the intensive care, mostly we are referring to the care offered inside the ICU settings. So where a patient is requiring special medical treatment and they need constant observation and monitoring to try to save or to relieve the suffering for patients who are critically sick. Next slide. The intensive care unit and critical care unit, they are both departments inside the hospital setting where patients are admitted when they are very sick. Generally, in intensive care units, patients are referred there when they have organ damage, which can be managed in the short term. But if not taken care as emergency, patients can deteriorate quickly. But critical care units or CCU, which sometimes is referred to cardiac care units, mostly in some hospitals, it's reserved for patients who are having cardiac conditions, like patients with heart attack or patients who had cardiac surgery, but also patients who are comatose or who have terminal illness. They are taken care in the critical care units. So when we are talking about intensive care unit and critical care units, it's more of the organization inside those units rather than the equipments in the room themselves. Next slide. So who is a critical patient? So a critical patient initial is a patient whose condition deteriorates acutely while they are hospitalized. Those patients often will present warning signs just a few hours or minutes before they have the clinical deterioration. And this is the time where you need to alert the rapid response teams to try to intervene in this critical period so that interventions or critical investigations can be ordered to try to manage those critical patients so that some may avoid being admitted in the ICU or they have early admission in the ICU and managed in the timely manner. Yeah, sorry for this interruption. So those critical patients, when they are identified in the medical and surgical wards, uh, which is the single most intervention which can try to save the patients or which determines the outcome whenever they go to the ICU. If you identify a deteriorating patient, you have to call for help from the rapid response team. And these rapid response team are different from teams that are generally called for code blue, or when there is a cardiopulmonary resuscitation requirement. So you have to know in the critical care continuum, when patients are admitted in wards, you have to continuously do a surveillance for a patient who might need ICU, or who might need a critical intervention from either intensivist uh, or respiratory physician. Next slide. So we need to know how we can interpret the vital signs. They are essential in detecting a patient who is becoming critical, or who is deteriorating clinically. And these vital signs, everyone knows them, but the interpretation is a key in managing patients who are critically sick. So for the temperature, it's in the range between 36.5 to 37.5. So above that, it's fever, and below it's hypothermia. And the heart rate, the normal is between 60 to 99 beats per minute. Uh, and the blood pressure, the normal, the cutoff is 120 over 80 millimeters of mercury. So when the systolic is below like 100 millimeters of mercury, your patient is hypotensive. So the respiratory rate, you have that range. If it is more than 60, maybe it's tachycardia. And the oxygen saturation, 95 to 100% being the normal one. And we shall see for some particular patients, the targets oxygen saturation when we are managing them in the critical care settings. So the next slides, we are going to see how we can interpret each of those vital signs, and we are going to start with the temperature. Next slide, please. So for the temperature, a patient may become hypothermic for different reasons. And most of the time when someone has fever, we think of infection, and the infections can make your patient deteriorate very quickly if they have like a bacterial infection. So an infection may be from any source, from skin to internal organs, all the systems can get affected. So also we have non-infectious causes of fever, like endocrine emergencies, like thyroid storm, where a patient with thyrotoxicosis is having excess release of thyroid hormones in the system. And this can give very high fevers in the range called malignant hypothermia, in the range of 41 or 40 Celsius. Medications as well can cause fever or hypothermia in patients. For medications, what I can say is that it has to be a diagnosis of exclusion. After exploring all the possibilities, you may remain with the medication as the cause of the fever. So this is a busy table, but generally the key message is to show you that fever, as it's misinterpreted in the clinical practice, some people think it's a lack of antibiotics, and they throw out antibiotics to try to fight the infections, which is sometimes is not the case. So you can have a range of conditions which are non-infectious, like oncologic condition, neurological, like intracranial hemorrhage or subarachnoid hemorrhage, autoimmune condition, or collagen vascular diseases. But we also have cardiovascular conditions like myocardial infarction, pulmonary thromboembolism, they can also give fevers. In hypothermia, there are conditions where you have decreased heat production, like in the setting of adrenal insufficiency, hypothyroidism, like in the myxedema coma, which is the extreme hypothyroxic or hypothyroidism status. So hypopituitarism as well can cause hypothermia, hypoglycemia, and other conditions, and as you can see. Next slide, please. Next slide. Yes, for the heart rate, we can have tachycardia where the heart rate is above 99 beats per minute, and we have bradycardia as well. So most of the time, tachycardia is like a reflex or adaptive mechanism when like someone is having decreased oxygen delivery, the body tries to compensate, like in the case of shock, hypoxemia, anemia, but also in status of increased oxygen demand, like in infection, like hypermetabolic state in hyperthyroidism, when someone is exercising, in a stressful condition, when someone is having pain, when in a status like withdrawal, alcohol withdrawal syndrome, when someone is hypoglycemic, uh, the sympathetic system gets into action, and the release of catecholamines will stimulates the heart, and you get tachycardic. Dysrhythmia as well, like supraventricular arrhythmias, ventricular arrhythmias as well can give tachycardia. So just when you record on the pulse oximeter, a high pulse, the tachycardia, try to interpret, not just take it as an easy thing. It can be from a critical situation like a ventricular fibrillation or ventricular tachycardia. So bradycardia as well can be critical for some patients, especially when they become having they have altered the mental status with bradycardia. You have to try to you have to detect it and see what could be the cause and intervene as early as possible. So next slide. So for the blood pressure, which is also a critical vital sign, uh, you know it's a result of cardiac output and systemic vascular resistance. The cardiac output itself being a product of heart rate and stroke volume. So if any of these is decreased, the blood pressure as well decrease, and your patient may become hypotensive, and the vital organs blood supply is impaired, and organ damage can settle in place and make your patient deteriorate quickly. The hypertension essentially it's most of the time primary, around 85 to 90%. You don't have the exact cause, but you can have hypertension from secondary causes. Like most of the time, in the secondary causes, it's renal parenchyma disease, either diabetic nephropathies or polycystic kidney diseases or pyelonephritis. So other endocrine like chromocytoma, Cushing syndrome, thyroid disease like hyperthyroidism, they can as well give hypertension. So whenever you are evaluating a patient and you see hypertension, try to see if there is something suggestive for secondary causes. not simply saying it might be primary. Generally, patients who are below 30 years, when they have hypertension, try to look for the cause. If they have obesity, try to see if it's not Cushing syndrome. If they have very rapid or fluctuating hypertension and headache, you may think of pheochromocytoma. And if your patient is having like proteinuria or they have abnormal renal function test, try to think of renal parenchyma disease as the cause of secondary hypertension. So hypotension as well can be from different causes, which I can't go into details. There are things which can decrease the heart rate, things that can decrease the stroke volume, but also there are things that can decrease systemic vascular resistance. Next slide. Next slide, please. All right. Now the next vital sign is respiratory rate. The critical patient may be tachypneic or bradypneic. You aim with the normal respiratory rate, 12 to 16. Out of that, you try to see if there is something critical for your patient. So there are pulmonary causes for tachypnea, cardiac, hematologic, metabolic, and others. And as we said, pathophysiologically, most of the time, uh, they come, the body tries to compensate or to adapt when there is something abnormal. So in the pulmonary conditions, that's the mention few conditions can have asthma, COPD, pneumonias, and pneumothorax as causes of tachypnea. Cardiac conditions as well, like ischemia, uh, pulmonary embolism, pericardial effusions, congestive heart failure as well, anemia, and other metabolic conditions. So sometimes you can have, in emergency rooms, you can have psychogenic causes of tachypnea where you have hyperventilation syndromes. You have to do a custom tailored evaluation to see if it's not anxiety causing tachypnea rather than asthma. You have to be to make a clinical judgment. So bradypnea as well, it may result from medications like opioids or sedative hypnotics like benzodiazepines. Alcohol is where as well can be a respiratory depressor and cholinergic medications as well. You can have neuromuscular conditions like myasthenia gravis and amyotrophic lateral sclerosis, which can give bradypnea as well. Next slide. Next, yes, please. Then we have oxygen saturation, which is also a critical vital signs that we have to evaluate for critical patients. So generally, in the usual population, we, as we have seen in the previous sessions, that we need to offer oxygen when they have saturation below 92. In the COPD, you intervene when the saturation is below 88% on room air. And causes of hypoxia are multifactorial. There are many. You can have from environmental causes when you have raw oxygen in the ambient or on the in the environment, but you also have pathologic etiologies as causes of hypoxia. So there are different categories. You can have conditions where you have raw inspired oxygen, like in carbon monoxide poisoning, like in a situation where you have at high altitude. You can have hypoventilation states. You can have a ventilation perfusion mismatch, diffusion abnormalities as well, and right to left shunts can also give hypoxia. I will not pay much or spend much time explaining this, as we have seen them in the previous sessions. It's just to make you aware that if someone is hypoxic, think of a possible cause rather than treating symptomatically and not looking for the secondary etiologies. Like if someone is having like pneumothorax, you may treat that with a simple chest tube placement or needle thoracotomy uh, procedure. Next slide. So we are approaching where the critical care occurs. Generally, usually critical care is offered in the ICU setting, but for any patient who is critical, you need to give appropriate intervention uh, at the site, not just waiting for sending your patient in the ICU. Like a patient in a medical ward or surgical ward, you need to manage airways at the site and optimize your patient before transferring to ICU. So as you have seen, the critical care continuum, it's in the pre-ICU, ICU, and post-ICU. You don't need to. You only need to coordinate all the services, and if any member of the rapid response team is attending the patient, they provide the required critical care at the site, either emergency room or medical or surgical ward. Next slide, please. So in the pre-ICU, we have pre-hospital setting and in-hospital pre-ICU setting. So in the pre-hospital, mainly we are referring to what is happening in the public environment, and it's the first aid is offered, and sometimes resuscitation can be undertaken, either in a case of accidents or in a case of like heart attack or whatever happens in the pre-hospital settings. You try to do the first aid for the patient and communicate with medical services and any personnel in the public who can help and organize a quick transfer to hospital setting. And generally, the pre-hospital aspect, it is dependent on public awareness, like the institutions or health facilities, they need to train the public uh, what they can do as in the first aid or a very quick resuscitation, which is non-invasive, which can be saving for patients who are really needing those interventions. So when the patient reaches the hospital settings in the pre-ICU category, so the aim is to detect who can deteriorate and who is really can need ICU or critical care unit admission. And this is achievable by the skills you have to interpret the vital signs, how you can appraise the clinical status, whatever elements you gathered from history and the labs, and try to anticipate who can deteriorate. If I can give an example, if a patient comes in emergency room and you are suspecting them to have sepsis, uh, you can use the case of the quick sequential organ function status to detect or to predict who is going to have poor outcome if you don't start the sepsis protocol. So like every 1 hour delay in the ICU, it can result in a significant increase in mortality. So use your skills and interpret the vital signs, the clinical status, and the labs, and call area the rapid response team to come and review the patient and provide interventions in a timely fashion. Next slide. Now, for the critical care continuum, when your patient reaches the ICU settings, there are things you try to apply on your patient so that you prevent some complications. So one of the key things you can try to apply on your patients is to target tidal volumes that are too raw so that you don't harm your patients, and try to minimize transfusions if possible, and try to reduce sedations, and try to limit vasoactive agents if you can. If you have to win the vasopressors, you have to win them and not prolong them, because they can result in a severe weakness for your patients. So the opposite is you can do is you have to try to mobilize your patients as early as possible, and this goes together as the raw requirements of sedation. If you sedate your patients for a very long period, they want to be mobilized very early, and you have to you may extend the family visiting hours to try to increase the physical contact between the caretakers and the patients to boost the moral or the psychological impact for their ICU stay. Next slide. So in the ICU settings, when you are providing the critical care continuum, so you are looking how your patient may survive, but also you are trying to ensure the quality of life to be good when they will be out of the ICU in the rehabilitation settings. And you try to maximize the quality of patients whom you see they are in the dying process. You relieve the pain and you try to minimize or invasive procedures or treatment when those interventions are not going to change the outcome. So if you judge the interventions are not going to change the outcome, you have to initiate the palliative care, and know that you are not alone in the ICU settings. You are in a team, so you decide together. And if you make this judgment, you communicate to the caretakers and initiate palliative care if the interventions are not going to sustain life. Next slide. So the critical care continuum continues as well in the post-ICU, and in the post-ICU, uh, here this slide is to show you things which are done in the post-ICU settings, and generally before your patient is discharged to the medical or surgical ward, the ICU team needs to communicate with the, the people in the regular or the medical wards, but also communicate to the families of the patients to know when they may need readmission, because sometimes it happens, and what to expect when they are in the regular ward. So ICU team also needs to do follow-up visits in the in the medical or surgical ward whenever they send the patients, and in the medical and surgical wards, the monitoring needs to be continued so that any deterioration is detected area and the interventions are provided. So when the patient may be discharged from ICU and go to home or in a place where the long-term care is offered, as well, the communication needs to be crystal clear. Like the discharge form needs to provide relevant informations that are going to help the primary care physicians or the family to know what to do in the community. Sometimes also patients needs follow-up in their nearest clinics. They need to know when and after how many days or months they have to attend, and they need to know whom or who are the professions to be seen, either if they need cardiologists or if they need orthopedists or whoever needs to do a continuation of care in the community. The caretaker and the patients need to know that information. So there are patients who get recruited in the clinical trials while they are hospitalized, either in the ICU or in the regular wards. When they are discharged, they may need to do some tests in the follow-up or certain assessments. So they need to be communicated when and how long and whom to report those tests. Next slide. Next slide, please. So there are elements of quality care in the continuum care. And those elements, if you can summarize them in like 2 words, it's communication and teamwork. So between this communication and teamwork is in those different units we have seen, the emergency medical services, the emergency room department, the ICU, and the clinics outside in the community serving the patients. If this communication is not done properly, it can result in significant morbidity or mortality for your patients. So the critical care continuum, it's a model to try to address the gaps that may happen in the communications between those different levels of care in, uh, in the healthcare system. Next slide, please. now, before I end my presentation, we are reaching the goals of SPO2 targets in critical care for patients who are very sick. And the first category, it's for patients who are acutely ill adults, medical patients. So the recommendation is to stop oxygen therapy when the saturations is above 96%. So you target above 95, as you have seen. And the second recommendation is applied to patients who are having cardiovascular events like acute stroke or myocardial infarctions. So we suggest not to start oxygen therapy between 90 to 95%. And the third recommendation is to do not start oxygen therapy at or above 93% saturation. This is a strong recommendation after studies to see where the patients developing poor outcomes when they are given oxygen when the saturation is above 93%. Next slide. So for the recommendation number one, which is applied to acutely ill adults medical patients, this recommendation, it's not applicable to people who are having carbon monoxide poisoning or people with cluster headaches or people with sickle cell crisis or people with pneumothorax. So for these people, you aim an upper limit of oxygen target 97% or higher. And the recommendation number two, where you aim the lower limits of oxygen saturation between 90 to 92% in patients with MI and patients with acute stroke. Next slide.
Yeah, thank you.
Come to the end of my part. The next presenter will talk on.
Thank you, Dr. Veniste, for your presentation. Do you hear me?
Yes, please.
Yeah, thank you for your presentation. Just, I think people with some questions of clarification may write it down in the chat, or they ask at the end of our presentation while managing our time. So from your presentation, the critical care continuum, our audience heard about the concept of what we mean by critical care, and also the general practice we need. Mostly we emphasize on early detection of the deterioration of a patient wherever he or she is admitted. Know how to interpret vital signs you are reading on your monitors, not just managing the numbers, but try to think what could be the cause of your abnormal vitals. And then remember, in that critical care continuum, you need to work as a team. And so you have to do a rapid and early detection. And then your continuum of care may start from emergency room toward to ICU, back toward, and then home. So from this, you think about the key among all those things is team working from different stakeholders, and also have a good and effective communication. This good and effective communication together with the teamwork have to be a principle, a guiding principle in rapid response systems in everywhere in the health facility where you are working. either in rural areas or in the city or in the referrals. Let us invite Dr. Joseph to go through all principles, structures we may have to have a structured rapid response team in our different facilities. Dr. Joseph, welcome.
So thank you, everyone. Just before starting, of course, I introduce myself. You know, I'm Dr. Joseph Onyonzima. I'm a specialist in emergency and critical care at SYTEM. So I hope everyone is hearing me. I'm right?
Yes, we hear you. We are hearing you.
Okay, so thank you. So let's start by rapid response system, of course. So let's go on the next slide. In this presentation, everyone will be able to understand what is really a rapid response team, and everyone will be ready to use some clinical score, especially in patient who are deteriorating. Next, please. Okay, so what is rapid response system? So this in one sentence, when we say a rapid response team, we want to say a group or a team of healthcare providers who assess and treat a patient who present or sign off deterioration in hospital, not in ICU. There is someone who report the patient deteriorate, and we call it the team will come in assistance. So of course this system is based on two key elements. So the first one is early detection of a deteriorating patient. So another element would be a rapid response. So and we will see how we can use this system in our settings. Of, for example, here I'm working at Shibe. So really it's not strong, but we have what called resuscitation team. So I can make kind of comparison. When in ward the patient collapse, they call by using a well-known cell number, and this team will intervene first in the ward. So let's go next slide, please. So let's start by clinical score and the application in our settings. Here we see three scores. The first one be key SOFA and MEWS and key CSI, especially in COVID. So those scores were developed really to assess the patient risk for deterioration, and they are not, they can't be a substitute of methodological interpretation of patient vital signs. As Xavier said before, those can't replace patient vitals. Next slide, please. Next, okay. So let's start by key SOFA score. So this stands for quick sequential organ failure assessment, and this is a team of nurses were passing it through doing resuscitation. Sorry. So this stands for quick sequential organ failure assessment, and it's a simplified version of the SOFA score. So everyone who passes in the ICU and in emergency, they know this score, I think. So and this one, this criteria will help is having three clinical criteria. We will see in the next slide, and this one is validated, and it will help us to identify patients with suspected infection that's at high risk of poor outcome. So it means the patient in ICU, more than 3 days, this patient may die or might deteriorate more. So, or out of ICU, this patient can't reach on day 3. Of course, in ICU, they have because you have a high or even advanced care. So next slide to see those criteria of key so far. So the first one, the patient is hypotension. If a patient is having a systolic blood pressure below 100, just to give one. If the patient is having tachypnea above 22, you give one. And then when the patient is altered or the GCS is below or equal 14, to the patient is not fully awake. Do you remember you have a normal glycemia? Then you will give one. So, and by interpretation, if a patient is scoring one, really, it's not alarming. There's not high risk of in-hospital mortality. But if the patient is scoring 2 to 3 score, this is high risk of hospital mortality. Next. So those another clinical score, which really is familiar with probably everyone who passed in emergency and critical care. So this MEWS score, modified early warning score, really were all people who are used to do a triage at emergency in the ICU, probably in OPD also probably. They might know this one. So this one will determine the degree of illness of a patient, and it will help a clinician to predict patient clinical deterioration. So if the patient is scoring above 5, so really this patient is likely to die in ICU. So of course for those score in MEWS score, it's any single parameters which is high scored as 3. Did you cause that it's really an alarming sign. So let's go through the score on the next slide. Next, and we see all components of modified early warning system. So here you can see we have, I said, respiratory rate, heart rate, systolic blood pressure, conscious status, and the temperature. So those are the key. We are using them to identify our patient based on their severity. So of course, those are vitals. And when you go to vitals, you draft it and you plot it like chart. There may be, for example, respiratory rate, patient might have 25. So then you come in the length to 12, this would be 2. This parameter would score 2. And the patient may be heart rate of 75, and then we get it's normal between 51 to 100. Okay, you score 0. And systolic blood pressure, take 105, and you come, you plot it, you find it's scoring 0, this range. And then you go on the GCS, maybe so a patient is responding to pain. So then you come on the where you plot here, you score 2, and then you take your temperature, maybe 38. Then if 38, you come in, you score 0. So then later you make a sum. So this patient got respiratory rate 2 and conscious, you go 2, in total is 4. So then you come with the left side, those color green, yellow, orange, and red. So a patient was having 4. So this orange 4. So those color, let's go talk to them. So the first one, if the patient is red, so it means he's scoring about more than 60. So really this patient need an immediate intervention. So if the patient is scoring between 4 to 5, it means this patient needs a rapid assessment or intervention in 10 minutes. And if the patient is in yellow, it means is scoring 3. So this patient, we may wait 1 hour on observation. So, and if the patient is scoring below 3, it's a green. So those are kind of OPD patient. This one might wait even up to 4 hours. So really, this one, you know, is helping us in our triage, in ward, in emergency, in ICU, really. And I hope we are familiar with this one. So let's talk the next slide to see the another score. Next, please. So, next. Okay. So the next one is quick COVID-19 severity index score. So of course it's new as the COVID pandemic, it's new in the worldwide. So this one will help us to predict 24-hour risk of critical respiratory illness in a patient admitted for COVID. Of course, the risk of critical illness or death in the 24 hours, it will be defined by oxygen requirement. So more than 10 liters by minute on any device which will be used. So next. Okay, so this score, COVID score, this is a simple formula where you get respiratory rate, and you see on the right side, they are range. If your patient is the range, you give this mark 0, 1, or 2. The same for pulse ox. Pulse ox SpO2 above 92, 89 to 82, and below 92. Then you give a dose. You give a dose max. Of course, if the patient, of course, you know, COVID, the people are on oxygen. If the patient is requiring below 2 liters of oxygen, you give a 0. So if it's between 3 to 4, you give 4, and 5 to 6, you give 5, and above 6 to 10, you give a 6. So and then at the end of this, we will interpret, like you'll see on the next slide, and we see how we will interpret those score. Next, please. Okay, thank you. So, as I told, after giving marks-based score based on those parameters you said before, of course, if someone is scoring below 3, the risk of deterioration for COVID will be low, and the risk of critical ill in the 24 hours will be at 40%. So where someone is scoring, you see, it will be a kind of intermediate risk level, and the risk of deterioration will be 30%, and 7 to 9, really, this will be high, really alarming score, where your patient 44% will be a risk of critical illness, and 10 to 12, it will be the high score, and really the risk of critical illness will be at 57%. Of course, this oxygen requirement, as I said before, for whoever with any device of oxygen delivery, we say this oxygen, this patient will require oxygen more than 10 liters by minute, or death. Of course, we're saying the risk of critically ill at 24 hours. You know, those the chance, those the percentage we're having, really, those are the risk of increasing oxygen above 10 liters, or also at the risk of death. You know, when the COVID patients passing a lot of time on COVID, you know, the end result, those patients, they are dying. So let's go on the next slide, where we'll see the management of critical action. It means what we can do on our patients. So the management, of course, once the clinical score identify a patient at high risk of deterioration, really, that patient need the medical team. We need the medical team to assess the patient and identify the cause, even address it on management. Of course, the dosage score can be used by any healthcare provider in a proper training. So if someone's familiar with dosage score already, just don't hesitate to use them. They are validated. And of course, it means that to be used on a regular basis rather than once on admission. So it means you can't use a scholar on admission emergency, then you don't use them again. For really assess your patient, you assess their risk of deterioration every time, every day, by using those score, as we're familiar with some of them. So let's go on the next slide. So the next slide, and see really some like threatening signs and symptoms which require really emergency or immediate intervention. So of course, let's start by a heart rate. Thus, if a heart rate is above 140 or it's below 40, really this is an alarming emergency. Please call your rapid response team. So if a patient is having a respiratory rate above 28 or below 8, so when the patient's systolic blood pressure is above 80 or below 90, this emergency hypertension or shock. So of course, hypoxic patient will need an intervention, or patient who have acute change. Sorry?
Yeah, keep going. I thought that your internet has been disrupted.
Okay. So any patient with acute change in mental status, or patient who are presenting oliguria in a short time, or any patient where a staff member with significant concern. So please, I will come back on this, because those above, we're familiar with them, those are vital. We're dealing with them every time. So, but really, if a nurse or a paramedic alarm you, say that there is any new concern or a patient, please don't delay to intervene. Of course, other additional criteria used by some institution, especially chest pain and relieved by nitroglycerin, probably. So it means you think a patient having angina pectoris, you give nitroglycerin to relieve it, but it's not helping. Please make sure you are calling for help by your response team. So of course, the patient having uncontrolled pain or unstable airways, or patient is having an acute seizure and you are not comfortable to manage them, please call your rapid response team. So let's take the next slide, and we start with see what you call rapid response team. So as you know, as I said before, this is a team of healthcare provider who assess and treat the patient with sign of deterioration in hospital. So let's take an example. I told you that we may call it in a resuscitation team in some our different hospital. So, but even it's not hospital, take it like we have in Rwanda. Even it's out of the hospital, let's call it SAMI. I think everyone in Rwanda knows SAMI. So that can be a rapid response team out of the hospital. We wish to be that system of SAMI out of the hospital to come in hospital, in the patient who are admitted to the hospital, and then when some patient in the ward is deteriorating, they can call this team for help. As I said, just make that comparison, and it will be very easy for you to understand what you call rapid response system. So we go to definition. So let's take the next slide. Okay. So here, as I said, This system, of course, is over a lightning structure, which will coordinate all teams involved in the rapid response call. Of course, you know, if you call, you got medical doctors, nurses, paramedics, laboratories, technician, even administration. So even ambulance team, if possible, you will get it. It's a team. It's a team. It's a team of 8 people, and these team steps really. So this stands for S stands for status of the patient. This is then this T stands for team member, and then this E stands for environment. For sure, you have to call people when you have a good environment. So if there is a ban in the inside the hospital, in the ward, and there is a ban, so you can't call them people from outside to enter for support in the ban. It means you have to secure your environment. Of course, those P stand for progress toward the goal. So I did say really the main goal of the rapid response team is to prevent patient deterioration. So to prevent patient admission in the ICU. Today we're saying ICU outside the ICU. This is to prevent our patient to be admitted in the ICU. This is why we want to use the dose score literally every day to assess the risk of deterioration of our patient in the ward. So let's see the next slide. Okay. So, as I said, also rapid response system in different country, having a medical emergency team in Australia, rapid response team in the USA, critical care response team in Canada, and critical care outreach team in the UK. So those are different countries. They are none. So I don't know how do we call what do we have in Rwanda. We don't know. So, but what I know in where I worked a long time in the hospital, and we call it a resuscitation team or resuscitation committee. I think in every hospital, our guideline and standard we have this kind of a task force, a task area. I don't remember the term, but we have the resuscitation team. So I think after this, maybe we can advocate to make them a strong rapid response team. Because I know they are in the paper, maybe on some hospital or someone working with WIC. So I know at King Faisal they have resuscitation team, at Sashika they have. So at here at Sashibe we have. So even when I were at Ruhango Provincial Hospital, they have, even at Ruhengeri, when I was there last year, I don't know if they're still working, but really those team are needed as is planned by our standard of treatment. So next slide, please. Okay. So then here they're saying why should you care on those rapid response team. Really, our patients are dying every time in the ward. So for example, the patient is having like kind of femur fracture. So he's in the ward waiting for surgery maybe next week. So the patient have internal bleeding, tachycardia, no alarm, hypotension until the patient die. But if we use the dose score every time, every day, so really, our patient might be saved. Of course, this you need a teamwork everywhere, every time. It's a critical to successful rapid response. So let's take the next slide, and we see really what can we do? Why do we care again? So as I said, as I said before, our patients are dying in the ward. We don't do CPR, we don't give oxygen, we say, this one is dying. So, but maybe we can do something before a patient deteriorate. So, in our hospital, emergency, the emergency, before the patient collapse, for sure, if you follow it very well monitored, you will see the kind of warning sign. As I said, tachycardia, hypoxia, altered mental status, and whatever. And of course, all critical patients are preceded by warning sign, really, even if our average of 6 to 8 hours. So to the patient might come to you, you come on a morning shift, and you say a patient is tachycardia, you give IV fluid, you give painkiller, and you didn't alarm. Then after 6 hours, your patient arrest, really you don't know what's going on. But remember that before he gave you some alarming cell like tachycardia, hypotension, that really it means any change, any abnormal vitals, especially alarming vitals, please call for help and call your team, your support team, and you can help a patient. Of course, those patients are dying because we are fearing, maybe due to our organization, maybe we don't have enough knowledge to know if the patient is deteriorating. If you don't know how to interpret your pulse oximeter, and your patient will die. Of course, a failure to appreciate clinical urgency. Really, we should know what is urgency, what is not urgency, what need close monitoring, what need alarm, what need immediate intervention. Of course, lack of supervision in different hospitals or department. Of course, really, there were some people who don't want any advice. Just someone there, and a nurse come to tell someone, a doctor, please, doctor, this patient is deteriorating. A doctor really say, no, I did my round in the morning. I know the patient is stable. Just do this, and that he don't come to see the patient. So please, our patient, ours, let's really we care our patient. So next slide. Let's see how we can implement this rapid response team. Of course, it's really difficult to introduce, but as our standard, as I said before, in our hospital, this component of having a resuscitation committee, that's not accreditation survey only. We can put it in our hand in daily practice. It's very easy. Of course, I need a senior leadership, identify key staff for rapid response team. Of course, to establish alert criteria and the mechanism of calling, if maybe you can just say phone number or whatever. Of course, develop some criteria and protocol. Of course, you can use a validated tool. Of course, really to get a feedback mechanism. So, in most of our countries, people are fearing of getting a feedback. Really, feedback, either negative or positive feedback, it's not a blame. So I can give you a feedback because you didn't take the SPO2, the patient. It's not to blame you, it's to help you to do better on the next patient. Of course, really based on our institution, this rapid response system, it can be customized based on our resource. So we're having all materials to give this one. We have those vitals machine. We have everything to learn this system. So next slide, and let's go next slide and see how can make a structure. Okay, thank you. So you can ask yourself which component we need for rapid response team. Of course, at least we need four components. The first one will be an activator. So activator is someone who will be with the patient. someone who will be daily on the patient. So in our sense, we can say a nurse or a patient caretaker. This can be an activator because someone who will see, my patient is deteriorating. So another one, it will be the responder on effluent rim responder. So it means if the patient is on the bedside, who will call for help? Who will respond? Who will respond on the call? That will be called a responder. So those responders will be, of course, will be those resuscitation team. Of course, we need administration. So, you know, in our settings, in hospital settings, everywhere, so you can't be a doctor in the hospital, you can't manage a patient without having administration, because they will provide every needed materials, medication, and whatever you want to have your patient, it will come from your administration. And of course, we need a quality improvement team. It means a quality improvement team. So this means we have something which is being done on our patient. So we need people who will give us kind of regular support, regular assessment to see if we can improve this. Our microphone is not good. Let's increase the extension. Let's include this. So really, those are kind of a supervisor team, and really this is very, very important. So, and then those 4 groups: activator, responder, administration, and KI teams. Those they can make really a good rapid response team. So let's go on the next slide to see those components, as we said. Next, please. Okay, so already we said on this. I don't want to delay here. Especially, I want to emphasize on affluent team. Those responder affluent team. So where we have a nurse lead with critical care experience. So you can't make a kind of a team leader without considering his or her experience, because this one, he will be able to communicate to others, to give the order to others. You do this, really, or this, make sure if you want to implement this RLT. So remember to hear someone we compared with his knowledge. Okay, so let's see the next one. Next slide to see really who can be an activator. So of course, a first staff to someone who will be the patient, a technician, patient, family members, patient. It means anyone who saw the patient first, in deterioration. Anyone who saw any alarming sign can be an activator. So then we have the different system for activation. So here we talk about three activation system. The first one will be S-bar. So we are familiar, we are familiar with those S-bar presentation. So where this S stands for situation, background, what is happening on your patient, then assessment, how is your patient, then a recommendation request. So it means you might call someone. So here I have a patient with cardiac arrest. So this patient was having a head injury. So, and now the patient is arrested. We are doing CPR and no pulse, and I want you to bring a defibrillator. That's an example of S-bar. Next slide, please. Next, we see another system of activation. So you can use this one. I pass the button. So read this is very simple. This of course, this will be an introduction. You have to tell who you are and where you are. Then you say the patient, and of course the patient location, age, sex, so that if someone come, if you have a child, no one will bring add material for adult. So then assessment, of course, you will say assess your patient, say the patient is having this. Then you say to a situation. Then you can say really as if you say the code. If you have the code, maybe you can code red, code blue, red, black, depending on your patient. Then make sure, of course, I said before, you are safe. This is safe too. Then you inside the background of a patient, those or comorbidity or previous medical and surgical conditions. Then action, what you did yourself for your patient, and the timing, you say when it was done, and you'll be more precise. You say, I want you to come to me in 10 minutes or immediate. Just make sure you are clear with your timing. So then ownership, it means this is responsible. Make sure someone's having his role. Then the next, where we tell you what will happen next after you call. You may call just while you are coming, I'm doing this. That's called the next. I'm calling the patients like this. When we're coming, I'm continuing my CPR. It's kind of an example. Next. Okay. So all this one, activator, of course, the responder, as I said, I don't know this. It does the team who will come to rescue, to help your patient. And of course, activator are responsible for calling the responder. If a patient meet or calling criteria depend on your hospital settings. Of course, responder must reinforce the activator for calling. Really make sure someone is calling for a clear reason, and ask many times why did you call? Why are you calling? And then after arriving, please remember to thank the activator for this intervention. So remember, please, there's no bad call. If someone call alarming and you come, it's not alarming condition, don't blame him. Don't blame him. He got in mind he wanted to save her patient. So let's see the next slide. Next slide, please. Okay. So those the component and responsibility, really, as I told before, performance, knowledge, and attitude. All those are combined with the personnel skills. And we are doing this every time. We are hearing people based on performance, knowledge, and attitude, of course, and the skills. Because remember, there's no bad call. Please, if a patient is alarming, please call for help. Next slide. Okay, so I talk this on necessary teamwork, of course, leadership, communication, mutual support, and situation monitoring, all those one. So we help to care your patient as a team. So let's go in the conclusion of this rapid response team on the next slide to see barrier, really, which barriers we can meet, we can face in the case of rapid response team. So the first one, of course, we are a human being, you can't miss the conflict. Of course, a lack of coordination, of course, some distraction, fatigue, workload, you are having one nurse for 10 patients, 20, we don't know, misinterpretation of key, lack of clarity, inconsistency in the team membership, lack of time, lack of information sharing. So really, those are the group, a kind of a barrier which can face. So we can't face them at once. Maybe you can be one of them anytime you can miss. Of course, those are not, and even you can make a list of those barriers in our settings. And we are in a good position. If you face a barrier, of course, you will plan on next or on which or how you will resolve it. This will be resolved. You will get a solution for those barrier in in the feedback. So let's go on my next slide. Next slide, please, before closing. So a kind of a summary. When I say a support mechanism. So really, this rapid response system, we need a support. A support means a governance. Governance over your hospital settings. We facilitate the team in the standard calling criteria. Of course, they will call the clinical emergency response system. Maybe they can use the phone, they can use the links, the bells. So really, we don't know, but they will help you a calling response system. Of course, education so that everyone in the hospital will be aware of that. And then the quality, the QI team, as we said before, it will help in the case of evaluation. So really, I thank you everyone for understanding. I'm done with my slide. So any question you can ask or you can write it down in a comment and we'll get answer. Thank you.
Thank you very much, Dr. Joseph, for your presentation. I think things are clear about the understanding and the use of clinical scores and to predict patients who may deteriorate and need an admission in ICU or who may deteriorate and increase mortality to the patients. So application of these clinical scores are very important to our audience. Please try to use them. And once you correct with your vital signs, as we had in previous presentation, please try to involve the rapid response team, which to this time, as Dr. Joseph emphasized many times, try to review your policies on your resuscitation team and see if you really have this. We are talking about a rapid response system in terms of composition or in terms of stakeholders in your teams where you have. So you might have early detection with vitals and clinical scores, a rapid response team by structure and by policy. If you have a structured rapid response, in the chat, there is one question from the audience. It was asking, who will answer on it. He was asking,
so, or maybe,
he was asking,
sorry,
he was asking, a rapid response team can't be in ICU. How they call a response team in ICU. So I think we have to differentiate, as Dr. Venist in the previous presentation presented. There is a difference between a code or a resuscitation team and this rapid response team we are talking. So in terms of structure, in terms of organization, so as Dr. Joseph go through about the rapid response system, in terms of structure, those clinical scores and policies, let us invite Liberata for like 5 minutes to tell us how can we implement the policy we are developing in our facilities so that we conclude our presentation after her implementation of devices in our health facility. Liberata, the floor is up to you.
She's asking if she can be unmuted. Maybe Alana can help her to unmute.
Okay.
Hi, Libreta. You can unmute yourself using the unmute option. You already have the co-host access, so you will be able to unmute yourself.
Maybe she can't.
So if Dr. Pornel is around, can also back up her and presenting the implementation of the rapid response team after talking about structure and policy.
Thanks, Dr. Xavier and the team for this time. As we are aware of teamwork while in resuscitation or while managing patient, because you can't manage a patient alone. rapid response team, as it is said that the rapid response team have to be aware and to know when to intervene. As you see, failure in planning and communication will lead a failure to our rapid response team, and the failure to recognize when a patient condition is deteriorating is also a problem, and it will lead to a failure to rescue, and it is to become a key contributor to in-hospital mortality. The rapid response team is the key in our hospital to recognize one who is deteriorating so that resuscitation can be done as soon as possible to rescue the life of someone. Next slide. As an example of rapid response team, there is someone to activate using any means you have at your hospital. Maybe there is a microphone you can use to call for help. And then the component may come if you don't have an ICU physician. Maybe you have a non-physician anesthetist who can intubate if necessary. ICU or nurse in charge, other practitioners. There will be like a response team coordinator who will be leading the resuscitation activity. As you know, you need someone to transport the patient if you are done with the resuscitation while going to admit in the ICU. Also, you need security to, if, for example, is someone infected or if someone have to create a way, there is someone to organize that. And then the rapid response team have to be trained how to organize themselves, especially that the coordinator, how he will be organizing the response team to resuscitate the patient. Next step. Next slide. Okay. There is a detection steps in assessment of our patient. When the patient is coming, and there is he's collapsing, someone who is recognizing may call for help. And then it's when the response team will be coming and then do a quick assessment and then stabilize at the site before transporting to either to the imaging, either to the admission or to the advanced care. Next. Okay, there is when variation in performance of this rapid response.
Hello?
Yes.
Yeah, we can hear
you.
Thank you so much. Thank you,
Apollinaire,
for backing me up. Can I move?
Okay, thank you.
Thank you so much. So the next slide was about, yes, the evaluation in the performance of rapid response teams. It means what can hinder the good performance of these rapid response teams, as Dr. Joseph said in the previous slide. Sometimes when you have a deteriorating patient, we may fail to detect that the patient is deteriorating because there is a staff shortage. I know in some hospitals, nurses they have a shortage of nurses, where a patient can deteriorate unknowingly and you find he has had a cardiac arrest. You might be trained in different institutions and have learned different triggers, as Dr. Joseph said in the previous slide. So if you don't have a clear policy to follow in the hospital, you may fail to have a common understanding of what you are doing. Another issue which happens within the action, it's the hierarchy between the nurses and the doctors. Who decides who do this and that? So I know where nursing has advanced, a nurse can lead a team which is resuscitating. If he or she is having that skills, he can be a leader in the team and give some directions to follow. Next slide, please. Next slide. Now, for us to implement the rapid response teams, we need to have a policy in place. So just a simple question, where we are working, do we have those policies regarding rapid response team? Just chat in the box and see, do we have those policies so that we can do something which is documented? Do we have policy? Just chat. Participant, please chat. I wish to hear from participant. Can you hear me?
Yeah,
I wish to have a picture from where you are working. Eric and Shimimana, are you still with us? Eric and Shimimana, can you chat and tell us where you work if you have such policy? Do we have a policy? Just chat. If there isn't, because one of objective of this session is to review our policy or to create one if we don't have. So we need to hear from you. Do we have those policies? No feedback? Niringi Imana, are you with us? Please chat. Language is barrier. Allow me to translate in Rwanda. Dufite izi policies tugenderaho za rapid response teams aho dukorera. No response? Eric Nshimimana, Emmanuel Mutagoma, whoever is able to respond, please.
There is one in the chat you can refer to. There is one in the chat you can refer to from the audience.
Okay, from the audience, let me. Can't be. I don't see.
The last one.
Okay, she's. Team in our setting. Okay, resuscitation team, as Dr. Venuste was saying, resuscitation teams can be used as rapid response teams. As Venuste was saying, the difference would be sometimes those resuscitation teams comes in when someone has cardiac arrest, but rapid response teams should come in when they are triggers, they are alarming sign for a client who is deteriorating. So now policy. To implement this, we need to have a policy in place. So what should be included on a policy? We need to define well what is rapid response team. We define it. Remember, some hospitals may have different triggers than others. Then we use SEDA principle policy. Next slide, please. SEDA stand for situation, evaluation, decision, and actions. Go to the next slide, please. Situation, we know that. How do we analyze the situation? With evidences which are available, we know that rapid response systems can improve the patient's outcome, and they are able to identify those warning signs and intervene on time to save lives. So if we try to evaluate, we try to do like a self-assessment and check if we have those policies in our health facilities. Then we decide, do we have a rapid response team committee? We have to ensure that we have all stakeholders, including physicians, respiratory therapy where applicable, pharmacists where applicable. Then we need to set which time do we need to use for intervening for a different case. Then what do we need to do? We need to use existing protocols for our institutional resources. Then we need to plan to schedule some reviews to address any barrier. If we have a policy in place, we may need to change it and adapt it to the means that we have. Then we need to institute simulations and practice. For us, we need to exercise ourselves before waiting to have a real case. We do like simulations, scenarios, then we intervene and see how we will intervene when we have a real case in our hands. Next slide. On the policy, we need to define the procedures for activating rapid response team. We need to know who will call, how do they call. You remember Dr. Joseph when he was saying S-bar. S-bar, this is where you give a situation of what you have, the background, how have you assessed the patients, and what do you recommend. Who responds, who are coming to help, then who are the members of the team who are coming, and which expertise that do they have? Are they really coming to help? Next slide. Next slide, please. Then we need to define the role of every team member in the rapid response team. What are the role? We need to when we are assigning the role, we need to consider the common causes of rapid response teams. And we need to have someone who will be communicating with the family. You remember, the family needs to be kept informed about the progress of the patient. Don't forget family, please. Next slide. Then we need to define the supplies and equipment that we need for our RRT teams, which will help us to prepare our emergency story where applicable. If you don't have an emergency story where you are, you can just arrange yourself and those emergency medications, supplies, and tubes. Sometimes it happens that you have an emergency, but you miss like any sample. So equipment, you miss like a bag to bag for a patient. So if you are attending this session today, make sure that where you are, you have at least those emergency supplies and medication, those can be used. Next slide, please. Next slide. Then after this, within the policy, we had to define the disposition of the patients after our rapid response teams. Either the patient is stabilized and stay on the ward, or the patient is moved to ICU or is transferred to high level of care, or the patient is deceased and we try to give psychological support to the family. Next slide, please. So we have to document whatever we've been doing. You see on this file, we have the side of the caller, the someone who called. You have to record what is the time, what was the situation, what was the triggers, then the responders. What have you done? How have you intervened? This is very key to assess for the next time and see where do we need to improve and what do we need to do best to save the lives of our people. Next slide. Thank you so much. This is the slide for Dr. Xavier. The floor is yours, sir.
Yeah. Thank you very much, Liberata. Thank you very much, Liberata. So I have an echo. So do you hear me?
We can hear you.
Yeah, good. So Today, we talked about critical care continuum. We talked about vitals in critical patients and their interpretation. We talked about where critical care patients may be managed. And then we are ending up by interpretation of clinical scores, the institutionalization of rapid response system, and also by implementation based on policies. I think those are clear messages we have to take after this session. We are in part 2 of our 12 linked sessions. Part 2 talking about critical care in general. How can we organize and how can we save our patients who are in critical condition, as the topic is now critical care outside an ICU. So our take-home message from now, we need to understand that critical care is a continuum and is not limited to care inside an ICU. To recall you that people who are referring your patient to our referral hospital is not just you call and you accept the patient and then you step out from your involvement in the patient care. The critical care still continuing while you are waiting to transfer and arrive to the destination. Another thing you have to remember the oxygen should be provided until the SPO2 is reached, and you consider different clinical condition your patient has to your goal of SPO2. So remember different clinical goals, clinical scores, how they are applied and their interpretation to predict for the prediction of your patient deterioration, mortality, or ICU admission probability. So on early time, you have to have that early recognition of your patient to deteriorate or to need an ICU. Don't wait time to die and you call your resuscitation team. Is here where there is difference between rapid response teams or system and the code or resuscitation team we are having in our policies in different sales facility when we need some scores for accreditation points. So this is a system we must install in our hospitals, in our different facility for early recognition and rapid intervention before the patient called or before the patient had a cardiac arrest. So you define all stakeholders in your rapid response team you need. And then you remember documentation will help you for quality improvement and also for verification and for other legal purpose. This is the end of our today's presentation. Before I give some announcements, I would like to hear from the audience for some clarification. After the audience, I would like to hear from Alana because from the beginning I didn't hear her voice yet. And afterwards, I have some announcement like in some seconds. So, audience, send the chat if there is question you have to clarify. Next, please. Next, please. Next slide. Yeah. In the chat, we are having messages. They are like advices to different participants. So before Alana, I heard your voice. I hear your voice, please. Let me give this announcement, and then we will continue with it. We are announcing that from the previous 4 sessions, a CPD credit and the certificate and the progress of distribution. And as we agreed, you will receive certificates or CPD credit only if you attended 3 consecutive sessions, 3 out of 4. As we are starting the second part, also after 4 sessions, you will also get a certificate or CPD credit if you attended 3 out of 4. Each part is a 10 point credit, is 10 credit. So 4 session, 10 credit. For the people who are going to get their certificates, they are equal to 10 credits, and we're going to email you your certificates. The second announcement is from today, our time of session is no longer from 2 to 4, is from 3 to 5, as most of our participants and our spokes preferred, as they said, 2 to 3 is a busy time. They are giving medication. So from today, we are going to start 3 to 5. After our time, we go home. We are going to have a break of 1 week because, as you remember, we are having our session every 2 weeks. But as after 2 weeks, we may be in our Christmas and New Year holidays. We are not going to have a session 29. We will have a session next year. It will be on 5th January 2022. And from this, allow me to wish you a happy Christmas and a happy New Year 2022. I think it's this I have to
Thank you.
inform you. And Alana, I want to hear your voice for now. Thank you.
Thank you very much, Dr. Francois. Alana is not available now, but Oge is here for assist.
Okay, the same.
Yes, the same.
Yes, the same.
Thank you so much. It's a beautiful, or it was a beautiful session as usual. And thank you to all participants for staying with us. Thank you to all our co-panelists. We want to thank our partners, Echo India. We thank Project Echo. We thank Dr. Anna Maria Crawford of Stanford Medicine, Division of Global Health Anesthesia, for developing this material for us. And we ask our participants to please visit our site, which has been shared earlier, and register for free to have access to this resource so that you can have access to, access it at your own time. Also, as Dr. Francois has said, our next session is coming up on the 5th of January. It ought to be in 2 weeks' time, but because of the holiday, Dr. Francois has asked that we don't interrupt anybody's holiday with the session, so that we can continually have full participation and be understood with him that it's necessary. So the next session will be on the 5th of January. So please, let's tell our colleagues, let's tell everyone to please come along. And also, like you mentioned, we will be having CPD points from the previous first 4 sessions. So if you've attended 3 times, and not just attending 3 times, but each of the 3 times you stayed for at least 30 minutes, then you can be eligible for the CPD. So in case you say, I'm not eligible and I've attended, if you attended just twice, please, you're not eligible. You have to have attended 3 times and have stayed for at least 30 minutes for each of the 3 times. Is that correct, Dr. Francois?
Yes, that is correct.
Okay, so thank you. If you have questions.
But to add it to you,
yes, sir.
In order not to discourage the people who attended like 2 times in the previous parts, if they continue to attend for the remaining sessions, at the end of 12 sessions, we will also consider whoever attended 9 out of 12 sessions equal to 75%, and we will deliver this general certificate with 30 credits. So people who attended the 2 and are not going to get a certificate for now, they may keep attending to reach 9 out of 12 sessions at the end. Thank you.
Okay. No problem. We'll work towards that. So at the end of this draft session, we'll revisit this again. But based on this particular CPD, it's divided into 3. So for the 1st to the 4th session, we have 1 CPD credit. From the 5th to the 8th session, another one. From the 9th to the 12th, another one. Then after the 12th again, we have a certificate based on your attendance level. Thank you for that. Please, if you have questions, email us at echo@assistinternational.org. I think that's all for now. Thank you again. We really enjoyed today's session, and have a beautiful holiday. Merry Christmas, everyone, in advance, and see you next year. Thank you.
See you next. Okay. See you.
Okay.
All right. Bye. Bye for now.
Yeah. Bye for everyone.